postpartum hemorrhage come into practice, and on behalf of the community, want to extend warm greetings to each one of you joining from across the globe. And as a community, this is a shared commitment for us to improve on maternal health outcomes, addressing one of the key leading causes of maternal mortality, that is PPH. And we invite you to this exciting webinar. That's a very interesting talk to introduce Andrew Weeks, who is going to be the main facilitator for this webinar.
Okay, thanks very much, Sam. I think we got in just before your Wi-Fi connection kicked out. So thank you for that warm invitation. I hope people could hear clearly. So my name's Andrew Weeks. I'm part of the steering committee for the PPH community of practice, and I'd like to welcome you all today. There's about 300 people signed up, which is great. The community of practice covers a wide range of practitioners and academics, practitioners, midwives, hematologists, obstetricians, medical officers from around the world, and is an attempt to try and connect the more academic work that WHO does with the practitioners on the ground. Now, of course, it's been a tough first 6 months of the year, and it's often during that time that you can feel despondent and you think, oh, there's things which we're not comfortable with, but actually, when you look overall, the views are good. And so the aim was in this seminar that we should try and provide a little bit of a helicopter view over what's happened over the last 25 years, where we're up to, and we're very lucky to have some fantastic speakers with us this afternoon who are going to talk us through that, both from a high level of what's happening overall in maternal mortality around the globe, but then actually what are the causes of it, and then an example of what projects are actually taking place. Next slide, please. So we do have French interpretation for those of you who are preferring French. You'll see a globe at the bottom of the screen for interpretation. Pour l'interprétation en français, cliquez le globe en bas de l'écran pour l'interprétation simultanée en français. I hope that came across okay. My French is schoolboy French, apologies. If you are being interpreted, then using the interpretation, then you can mute the speaker's audio so as not to get distracted, so you don't hear the two at the same time. Vous pouvez couper le son d'origine en cliquant sur Mute Original Audio. Next slide, please. So there's our agenda for this afternoon, for the next hour and a half. We're going to have something like 20 minutes of talks each, followed by a question and answer. So we'll have Lale Say first of all, and then Jenny Cresswell, both from WHO, followed by Ken Mugabe from Uganda, talking about policies they've put in place to reduce PPH deaths. Next slide, please. So the chat box is open, so please introduce yourself in the chat box and feel free to use the chat box for comments, but if you've got specific questions that you want to ask, then please put your questions in the question and answer box. I think you're used to this by now, aren't you? But there's a Q&A box down at the bottom there. For most people, I think, and then at the end of each talk, we'll go through the Q&A box. Next slide, please. inevitably, there may be medical images within the presentation. So just a little bit of a warning that occasionally that can discretion is advised, shall we say. So we don't intend to offend, but sometimes these are necessary for medical illustration. Can I just check that the French translation is coming through okay? Okay, well, I think if that's all okay, we'll move on without any further further change then to Dr. Lale Say. Thank you very much for joining us this afternoon, Lale. So Lale Say is the head of SRH integration in health systems in the Department of Sexual and Reproductive Health and Research at WHO in Geneva. She's had specialist training in reproductive health epidemiology and research at Edinburgh University and a medical degree from the University of Istanbul. So at WHO, she leads the health system strengthening, she leads the work on integration of sexual and reproductive health in health systems, leading the portfolios on health system strengthening, digital health, measurement and data, and humanitarian contexts as relates to sexual and reproductive health. She's been working at WHO since 2002, and many of you will know her work already. She's got increasing responsibilities in area of monitoring and evaluation, as well as global monitoring of maternal and reproductive health indicators. She also coordinates translation of sexual and reproductive health evidence in country policy and programs, and the work focusing on adolescent and at-risk populations. So before that, Lale, I think you were at Ministry of Health in Turkey and Obs and Gynae Department, University of Istanbul Medical School. And many of you will have seen her extensive publications. So without any further ado, I'm going to hand over to Lale to talk to us about the trends in mortality over the last 25 years. Over to you, Lale.
Thank you very much, Andrew, and thank you very much, everyone, for joining this important webinar. And good morning, good afternoon, good evening, wherever you are. As mentioned by Andrew, I'm going to speak a little bit about the latest data on the scale of the problem of maternal mortality globally, as well as the trends between 2000 and 2023. So the data I'm going to speak about, I'm sure many in this webinar are aware, was released in April this year, April 2025, on the day of the World Health Day as the main report of WHO for the World Health Day that looked at the trends in maternal mortality globally between 2000 and 2003. Again, as many of you may know, this effort is actually an interagency, UN agency's report, developed by a group called MEAG, Maternal Mortality Estimation Interagency Group, that is comprised of WHO, UNICEF, UNFPA, the World Bank Group, and UN Population Division. And this effort has started in as early as 1983, initially only as WHO and UNICEF, and the rest of the agencies joined later. And over the years, starting from 1983 up to this year, the methodologies have been improved, developed, changed on the basis of the new innovations and evidence, and also as well as the methodologies are engagement with countries, discussions with countries, and dialogues have enhanced over the years. I'm not going to go into very much in detail in terms of methodology, but I just want to focus on just a few key things, important things, when the maternal mortality interagency group is doing in developing the global estimates and updating them. First of all, I would like to say the estimates are, although based on a global model, statistical model, it is based on the country level data. And for all countries, we look for every recent data and update our maternal mortality database to ensure that we have all the data available is used according to the data type and the methodology of each of the data points. In this last round of 2023 estimates, we included 5,727 country years of data that covered the period from 1985 to 2023. Majority of this data came from civil registration and vital statistics, almost half, a little bit over half of it, and followed by the population-based surveys, DHS, and mixed data. As you can imagine, all these data sources, again, if I want to go back a little bit back, there are other types of studies, the specialized studies, the population censuses, ad hoc studies that we call miscellaneous studies, as well as the CRVS and population-based surveys. And obviously, because the methodologies used in these different data sources are different, even sometimes the definitions are different, like the DHS surveys use pregnancy-related death, while the CRVS sources use maternal death as the main analysis definition. So to account for these differences and as well as to account for the misclassification and underreported that is inherent in many of these data sources, this initial country level data is undergoing to an adjustment and processing before it is being a statistical model is applied. I'm not going to again go into very much details of the statistical model, but the aim is actually to come up with a comparable database of country level data that is adjusted for inherent biases, especially related to misclassification and underreporting. When coming back to data inputs, again, as I said, a little bit over of data inputs are from CRVS and the routine statistical data, and some of them, and the next bigger group was the DHS and mixed type surveys. And this graph shows the distribution of these data sources by region. And as you can see in many of the countries, especially Latin America and Caribbean and Europe and Northern America, the majority of data is from CRVS sources. But in Sub-Saharan Africa, the majority of available data is from DHS surveys. Some key findings from these latest estimates. Again, probably many of you have seen and have read in many sources, but the main finding is globally in 2023, we estimated that there was 260,000 maternal deaths. This means that an MMR of 197 per 100,000 live births. Those who have been engaged in this area of work on maternal mortality issues so long would maybe realize that for the first time, we found an MMR of less than 200 per 100,000 live births. So we have 197 per 100,000 live births estimated maternal mortality ratio, which will mean 712 maternal deaths every day, 30 maternal deaths per hour, or 1 maternal death every 2 minutes globally. Although compared to some other health indicators, this may seem like a rare event epidemiologically, still these numbers are actually unacceptable, and most of them, as you know, are preventable, and we'll come to that in the next presenters. Sub-Saharan Africa accounted for 71% of global all-these maternal deaths, followed by Central and Southern Asia, which accounted for almost 17%, and then the other regions are less. And the group of countries, according to UN classification, defined as the least developed countries, LDCs, accounted for 43.9% of maternal deaths in 2023. When we look at the global trends in MMR in between 2000 and 2003, you could see a decline. A peak, I'll come to that later at the COVID time, but then again, decline continued until 2023. So between 2000 and 2023, maternal mortality ratio fell by 40%, from 328 to 197, which corresponds to an annual average rate of reduction of 2.2%. But when we look at a little bit more recent time period between 2016 and 2023, MMR decline was 10%, or 1.6% average annual decline. So although overall it looks not a bad rate, 40%, the reduction seems to be slowed in the more recent years. And when we look at the regions separately, we see all the declines and the levels in 2000 and 2023, and then we see the highest ratios are in Sub-Saharan Africa, but still not a very bad trend, actually, quite a good decline we still see, although still the average numbers for Sub-Saharan Africa is quite high. The second biggest decline are seen in Central and Southern Asia, although in 2000 they had the highest the ratios in the highest decline seen in Southern and Central Asia. We see now in terms of the 2023 data, they had quite significant progress. Oceania, excluding Australia and New Zealand, are the third one, and then we see a slower progress as compared to other regions, and then the rest of the regions goes like Northern Africa and Western Asia, again, good progress, a little bit increase in the COVID area, but then, catching up pre-COVID levels. As you know, another indicator or statistics we use quite often is the lifetime risk of maternal death. That is meaning that the lifetime risk of dying of a 15-year-old girl from a maternal cause is, again, estimated as highest in Sub-Saharan Africa is 1 in 55, as you can see in this graph, which is approximately 400 times higher than what we see in Australia and New Zealand, which was 1 in 21,248, which needs to be addressed if we want to actually have the global progress, if we want to talk about a global progress in maternal mortality reduction. Few more slides about the country level progress. Again, maybe one thing although progress is still not as sufficient as to reach the Sustainable Development Goals, we still have one positive news to say, that in this round, we had no countries that had extremely high maternal mortality that is defined as MMR of over 1,000. 9 countries were estimated to have had very high MMR, between 500 and 999. You could see the names: Nigeria, Chad, Central African Republic, South Sudan, Liberia, Somalia, Afghanistan, Benin, and Guinea-Bissau. And 14 countries had a high MMR, between 300 499. 43 had 100, between 100 and 299. And 130 countries had a low MMR that is below 100. This is the map, as again, most of you, I'm sure, are familiar. The darkest colors are where the maternal mortality ratios are highest in the world. Again, as shown in the earlier graphs, is the mostly sub-Saharan Africa, some Southern and Eastern Asia, and some in Latin America. And the lighter colors are where maternal mortality ratios are lowest, less than 20 per 100,000 live births, or less than 100 per 100,000 live births. You have seen the peak in the recent years during the COVID time in the graphs that I showed you. And you have realized that in 2021, maternal mortality ratio rose in most regions, almost all regions, except Australia and New Zealand. But by 2022, maternal mortality ratio returned to pre-pandemic levels. These spikes we saw in the trends in 2021 was mirroring the excess deaths among women of 15-49, regardless of their pregnancy status. And then maternal death share of that overall excess deaths stayed stable during the pandemic. So we saw a peak inconsistent with the overall excess deaths of women of reproductive age. In this exercise, we also had 2 highlights. One of them, for the first time, we estimated maternal mortality ratios in small island developing states, which are regarded as SIDSs. These are 57 entities, very small islands, totaling to 65 million people, facing unique environmental and social challenges. And also measuring maternal mortality and estimating maternal mortality has been challenging in these places, because only because of the populations, small populations of each of these entities, it's a very, very rare event. But for the first time, we did these estimates, especially because of them facing unique environmental and climate-related challenges that also has an impact on maternal health and maternal mortality. And then in 2023, the estimated MMR for these small island developing states was 193 per 100,000 live births. The second, we also had a closer look on the maternal mortality ratio in fragile and conflict-affected settings. Again, this group of settings and countries are an important areas to actually to pay attention to in terms of many health issues, but also on for maternal mortality, and ensure the interventions are well implemented there. In our estimates, 61% of global maternal deaths in 2023 occurred in fragile and conflict settings. And these are 17 conflict-affected countries where MMR was averaging as 504, which is 55% of global maternal deaths. And MMR was 368 per 100,000 live births in the 20 social fragile countries. These are the World Bank's categorization of conflict-affected and fragile countries. So strengthening health systems and ensuring the interventions for maternal mortality reduction or maternal health are are implemented in these settings. That's the data. If we want to tackle the global maternal mortality, we really have to have a focused attention to these settings. And finally, what did we see? Do we see in terms of progressing towards achieving sustainable development goals? As you would know, one of the sustainable the third goal of the UN Sustainable Development Goals is about health, and the 3.1 goal or target of the SDGs is reducing maternal mortality ratio, the global maternal mortality ratio, to less than 70 per 100,000 live births. So our current progress, if you remember, is 197 MMR global, is too slow to meet the SDG target in 2030. If we continue with 1.6% of annual average reduction, which we saw in between 2016 and 23, MMR in 2030 would be 177, much higher than the aimed or targeted 70. If we are a little bit more rapid with 2.5% of annual rate of reduction, which we saw between 2000 and 2023, MMR would be still 169. And then if we want to have MMR less than 70 per 100,000 live births, that would mean that we have an annual rate of reduction, which is 14.8% from now, from 2023 to 2030. So we all have more work to do, all of us in this webinar, and globally everyone who is actually caring and passionate about maternal health, maternal mortality. So we have to advance progress. We have to ensure multi-sectoral or collective action is required to address all the causes. And you will hear from Jenny Cresswell just after this presentation about the main causes, and most of them are preventable. In addition to clinical causes, we need to address social determinants related to ethnicity, age, disability, or socioeconomic characteristics, and that specific attention is needed for humanitarian and fragile contexts. To be able to do this, we have to make sure maternal health and survival remains high on the global agenda. And finally, as the people who have been really passionate or really seeing the data availability and quality in developing the global estimates, we are really insisting that more work is needed to improve the measurement of maternal mortality. So with this, I thank you very much, and over to Andrew, I guess. Thank you very much.
Thanks so much, Lale. And it's sort of exciting news, isn't it? I mean, this is remarkable. 40% reduction in global maternal mortality. And I think sometimes if we're not careful, we lose sight of that. Actually, the trends are really most impressive. And it's thanks to many of the people on this call today. Yes. Huge amounts of work around the world going through, but it's also thanks to entrepreneurs and people running small businesses and people paying taxes that as economies improve, so you see improvements. So thank you very much. What I suggest we do is go straight on to Jenny Cresswell, because I think that the two presentations work yes. very well together. And then at the end of that, then we can we'll pull it together before we go into specifically what some countries have done. So I should introduce Jenny Cresswell, who's a scientist in the Department of Sexual and Reproductive Health at WHO. She leads the SRH measurement and monitoring portfolio at WHO, and she's got a background in epidemiology, demography, and social sciences. So her work focuses on research to better capture SRH within global metrics and technical support to countries. So there's probably no one better than to speak on this, given especially that she authored the important paper recently, which came out of WHO, looking at the specific causes of death. So thank you very much for joining us, Jenny. We much appreciate you taking your time, and over to you.
Thank you very much, Andrew. Good morning, good afternoon, good evening. It's a real pleasure to join you for this discussion on this really important topic. So as Andrew said, I'm going to speak in a bit more detail about the causes of maternal death and the data that we have on that. As my colleague Lale just outlined, maternal mortality remains a key global health priority. We have the Sustainable Development Goals. We all know what we want to do as a global community. The key challenge is how do we get there? Now, we know, and everyone on this call is acutely aware, that maternal mortality is one of the health indicators that has the biggest gradient, the biggest inequality between high income settings, between low income settings, and between different groups. And we do see this really shocking statistic that around 95% of maternal deaths globally are occurring in low income and lower middle income settings. Now, the reason for that is tragic. It's because virtually all maternal deaths are preventable. They're due to preventable causes if women receive timely, good quality care when they need it. Because some women are tragically not receiving that as is their right, we see this huge gradient about where deaths are occurring. So that is why we do this additional piece of work to the levels and trends, which my colleague Lale just outlined, to give more granularity to the causes of maternal death within that overall envelope, so that information can inform policies, programmings for ministers of health, for national statistics officers, and so that interventions can be well targeted so that resources can be expended in the most efficient way possible. Now, the work I'm presenting here is the first update in just over a decade to the global causes of maternal mortality. And it's also the first time that we included specifically maternal suicide and late maternal death in the analysis. So I'll come to speak a bit about that at the end of the presentation. So the objectives in the study were to estimate the causes of maternal death by region for the period 2009 to 2020. And we use 7 large groups to do that, which are abortion, embolism, hemorrhage, hypertensive disorders, pregnancy-related sepsis, other direct causes, and then indirect causes of maternal death. And these are groups which are following the International Classification of Diseases framework, which I'm sure many of you are familiar with, so ICD-10. We also describe data reporting maternal suicides and describe data referring to late maternal death. And I'll come to this in a bit more detail later, but the reason for these second 2 objectives, I'm using the word describe as opposed to estimate, is because, as you will see, the available data is incredibly sparse, it's incredibly weak, and so that we don't feel that we can confidently estimate for these groups of deaths, which is why we describe what's there, but we are a bit less confident in saying what the global situation is compared to the initial 7 groups of death. And then our longer term objectives are, of course, to use this data to inform, to make a difference for policies and programming, so that up-to-date data can be used and ultimately progress towards the SDGs is supported. So when we produce these estimates, we work very closely with the levels and trends work, which Lale has already presented, because it's obviously really important that all our estimates are consistent and aligned with each other. So a lot of the data sources we use are the same, but we can often only use a subset of the data, because what you get, particularly in areas of high mortality burden, such as sub-Saharan Africa, is that a data source may only report maternal death, but it doesn't say within the maternal death category, specifically what the woman died of, so hemorrhage or so on. So where possible, we use the same data sources, but we have less data compared to in our levels and trends work. So we collect data from different sources. We collect civil registration data, that's CRVS, from WHO's mortality database. And that is a database of all countries in the world, all member states who have a functional civil registration system, report their data on mortality to WHO annually. And they do that as a condition of being a member state of WHO. So we extract the relevant information for that. For countries which do not have functional civil registration data, we read the reports, which may be, in this case, either national or subnational, which are published by typically ministries of health. It can also be national statistics offices, or it can occasionally be another nationally recognized body. And where the reports are eligible, we extract the data. And then we also do a standard literature review using methods that I'm sure you're all familiar with, searching PubMed and other databases using a string of search terms to identify peer-reviewed journal articles reporting on maternal mortality. Because we are estimating globally, and of course there are many different languages in the world, we take a multi-strategy approach to the literature review. So we have one set of searches which goes in the Latin script databases. So that's things like your Medline and your PubBase, but also Global Index Medicus, which searches in Spanish, French, and so on. So your primarily European languages. We then had a separate search which used Chinese characters to search. So Wangfang and CNKI were the databases used there. And then a third set of databases using Russian script, Russian language searches. Where the cause of death is recorded as an ICD code, that's obviously ideal, and that's what we extract, but actually very, very often that's not the case. The cause of death is described in free text in the report. And we have an OBGYN on the team who, to the best of her ability, using the information available, assigned what was the appropriate ICD code using the information available. And the way our model works is if she's not certain, she thinks, for example, it could be A or B, and 50-50 or 20-80, she can assign those probabilities so that this uncertainty can be accurately reflected in the results that we produce. So this slide gives you a sense of how much information we have to search through and how relatively little information we're left with at the end. So our biggest source of data is the civil registration data on the left. So for that, we have data from 110 countries covering 908 country years, because obviously most countries contribute more than 1 year of data across the period we're estimating. Now that's our biggest source of data, but remember it tends to come from the higher income countries and the higher upper middle income countries, which have relatively fewer of the absolute burden of death taking place. Then our search of the Ministry of Health and National Statistics Office reports, we got data from 28 countries covering 79 country years. And then the big flowchart that you see in the middle of the screen is showing you the literature search. And as you can see, we had tens of thousands of records of abstracts, which were originally identified in total around 100,000 records. But we exclude the vast majority of these because the search strategy picks them up because they talk about maternal mortality. But for example, they're a commentary, or they don't have data on the cause of death, or so on. So we're not able to use them. We also have some additional inclusion criteria. For example, if the paper is talking on a specialized population, for example, only women who delivered by cesarean, or only women who had a particular clinical condition, for example, they were diabetic or so on, we also exclude those because we're trying to generalize the national level and the population as much as possible. So this was a very large literature research, and it is really important because this tends to yield the information which is available from the countries which are the highest burden, i.e. those in sub-Saharan Africa. But despite having to screen, 100,000 or so records, we ended up with only 20 countries covering 33 country years from that huge effort in all the different languages and all the different scripts. That said, we were really pleased with our search strategies this time. We had much more data than we'd ever had previously to do when this work has been done in the past. And we had at least one empirical input for 129 countries, remembering that WHO has 194 member states. So it's around 2/3 of countries we have a data for, which is brilliant, but also shows you that there is 30% of countries in the world where we have no data, nationally representative data, that is, of cause of maternal death. And a huge proportion of these are in sub-Saharan Africa, which we know is where the huge burden 7 in 10 maternal deaths are happening, which you need to really bear in mind when I present the results, because it's shocking that this lack of information is coming from where the need is greatest. The total of number of maternal deaths we had in empirical data set was 139,000. And that's just under 4% of the total maternal deaths, which we think occurred globally during that period. So good, but shows that a shocking number of women are dying without being counted in adequate records. As I previously mentioned, we analyze according to the ICD-MM framework. We do this using a Bayesian hierarchical model, and the reason we use that is because it allows us to appropriately account for the uncertainty inherent in the data. So where we have a weak quality data source, but we still want to be able to include it because it's better than nothing, we can still use it, but we can assign different levels of certainty to our inputs. So this is the most appropriate method statistically for us to use. And as I mentioned right back at the beginning, we just use simple descriptive statistics for the data on maternal suicides and late maternal death due to the lack of data. So you can see on the slide at the global level, the proportions of maternal deaths in the different cause groupings. And all the graphs I'm going to show follow the same format. They're all proportions. And the black bar around the proportion is showing you the 80% uncertainty interval around the point estimate. So the leading cause of maternal death during the period 2009 to 2020 was obstetric hemorrhage, which is the green bar in the middle. That's 27% of all maternal deaths globally. Overall, 73% of maternal deaths were from direct causes, so the top 6 bars, and 23% of maternal deaths were due to indirect causes. Hypertensive disorders is the purple bar, and that was 16% of maternal deaths, and 8% were due to pregnancy with abortive outcome, which could be either an induced abortion, or it could also be as a result of an ectopic pregnancy or a spontaneous abortion, miscarriage. You'll see now the similar graph, but this time disaggregated at the regional level. Again, it's really important to highlight that these are all proportions within the region. So they all appear the same size, but to remember, please, that 7 in 10 maternal deaths are taking place in sub-Saharan Africa. So that graph in the bottom left-hand corner is many, many times greater than the graph for Australia and New Zealand, for example. The proportion of hemorrhage deaths was highest in sub-Saharan Africa, 28%. And again, because so many deaths are taking place in this region, remember that when I showed the global level proportions on the previous slide, that is really being driven by what is happening in this region of sub-Saharan Africa, because that's where nearly all the deaths are occurring. And what's important to note is the burden of hemorrhage was 2 times greater in sub-Saharan Africa compared to the lowest burden regions, so which is Northern America and Europe. So in Australia and New Zealand and Northern America and Europe, 15% of maternal deaths were taking place due to obstetric hemorrhage. In Latin America and the Caribbean, the pattern was slightly different. So the main cause of maternal death in that region is hypertensive disorders of pregnancy, at 22%. And then the other thing which is really interesting to note is that one thing that is quite similar, at least when you look at it at this level across regions is the proportion of maternal deaths due to indirect causes. But it's important to remember that this group itself is a mix of deaths where the woman died as a result of an interaction between a non-communicable disease and her pregnancy, and a communicable and infectious disease in her pregnancy. So these are all mixed together in the same group. You have HIV maternal deaths and deaths due to non-communicable diseases all together in the same category, which is why you see relatively little difference taking place across the regions for that category. This table shows, specific for hemorrhage deaths, a breakdown by timing in the antepartum, intrapartum, and postpartum periods for hemorrhage deaths. And you'll see that most hemorrhage deaths are taking place in the postpartum period, with similar proportions then taking place antepartum and intrapartum. And this does vary according to region. You'll see this on the slide in front of you, again with Sub-Saharan Africa and Western Asia and Northern Africa showing the highest proportions of postpartum hemorrhage maternal deaths. And I think that will lead nicely into the presentation later by our colleague from Uganda, who will be speaking more about solutions and interventions to the problem. Just to briefly speak about suicides during pregnancy and postpartum, as I mentioned, this was the first time we had covered this in this work. Maternal suicide is considered a direct maternal death by the World Health Organization. However, it is particularly challenging to measure, to capture, because such deaths are not captured in civil registration data or in the MEAG estimates due to the way the ICD codes suicide death and what is the underlying cause of death. It's not possible to see whether a woman was pregnant. If you know where suicide took place, you know the age of the woman and you know it was a woman, but you don't know if she was pregnant at the time in the way the data is captured. So we can only look at this cause of death when specialized reports, for example, a confidential inquiry or another type of report is published by the government. And globally, only 12 countries were reporting one or more maternal deaths from suicide. And this varied very substantially by region. So for the countries in Sub-Saharan Africa that were reporting, it was less than 1%. Whereas in Australia and New Zealand, in their confidential inquiry, they're reporting 26% of maternal deaths are due to suicide during pregnancy and the postpartum period. The United Kingdom and Ireland, which have robust confidential inquiry systems in place, some of the best quality data in the world. They are reporting that maternal suicide is currently the third largest cause of direct maternal deaths occurring during pregnancy or within 42 days of the end of the pregnancy, and is in fact the leading cause of death of late maternal death, so between 42 days and up to a year from the end of pregnancy. Given that we're seeing this very strong differences in reporting, depending on the type of data and the type of reporting and quality, that is a flag that it's something which needs much closer investigation and much better data so that we know really what's going on. So systematic recording and reporting of maternal suicide should be prioritized, especially in lower mortality settings, where it seems to be a dominant cause of maternal death. The programmatic interventions for maternal suicide are likely to be particularly complex and need to involve a lot of different groups of healthcare providers and social care providers to work together. So having robust data on this is an important need, which we need to look at much forward. We need to look at a lot going forward. And then also to talk on late maternal death. So 111 countries reported at least one late maternal death. So that's a death taking place after 42 days up to 1 year postpartum. And again, the ratio of these deaths varied quite considerably by region, from less than 0.1 in Oceania to around 0.7 in Western Asia and Northern Africa. In 4 countries which had conducted a confidential inquiry that included late maternal deaths, which were France, Morocco, UK, and USA, The ratio of late maternal deaths to maternal deaths during the traditional period was higher. And in the UK, indeed, the UK reported a ratio higher than 1, meaning there were more late maternal deaths reported than deaths up to 42 days. The causes of death in the late period did differ. More deaths were due to mental disorders, diseases of the nervous system, cardiomyopathy, and other diseases of the circulatory system. So again, this is an area which we are aware needs much better data. And similar to maternal suicide, the fact that we're seeing these different patterns according to data quality is indicative that we are missing information and need to be much more systematic in future about how we make sure we don't neglect this group of women. So in conclusion, obstetric hemorrhage remains the leading cause of maternal death globally and is disproportionately affecting women in lower middle-income countries. The existence of effective clinical interventions means that deaths from hemorrhage are largely preventable. Most hemorrhage deaths taking place in the postpartum period, although we mustn't forget the antepartum and intrapartum groups because together those are important as well. Hypertensive disorders remains the second most common cause of death, and in Latin America and the Caribbean, the most common cause of maternal death. There has been no substantial change in the proportion of maternal death due to indirect causes since the previous 2 analyses that WHO conducted, and they remain overall the second largest cause of maternal death. Missing data and misclassification remains substantial problems. This is likely to be a particular issue for certain groups of causes, for example, indirect death and late maternal death, as I've already mentioned. Any death which is relatively more likely to take place away from the obstetrics ward is less likely to be captured in our data. The solutions are to strengthen civil registration, but also to triangulate data sources. So where a confidential inquiry exists, for example, make sure that there is a positive feedback loop between that and the civil registration so that all the data sources align. ICD-11 is currently being rolled out in many countries, so the 11th version of the ICD, and that contains many new tools to facilitate accurate cause of death coding. With hemorrhage remaining the leading cause of maternal death globally, the WHO roadmap for postpartum hemorrhage provides key priorities for research, norms and standards, implementation and advocacy. These 4 strategic areas were identified by key stakeholders to accelerate progress towards reducing deaths from postpartum hemorrhage. The dual challenge of direct and indirect obstetric causes highlights the need for a health system approach that integrates obstetric and non-obstetric providers across the continuum of care. And as I previously said, we need much more systematic evidence to be collected on late maternal deaths and maternal suicide so that we can see what's going on in these potentially important causes. Thank you very much for your attention. I will stop sharing my screen, but it's a pleasure I'm looking forward to the discussion.
Thanks so much, Jenny. That's fantastic. And maybe the panel can come back. Maybe Lale can come back, as well as Ken and members of the PPH steering group, community of practice steering group for comments. So thank you very much. It's fascinating. It's really interesting and exciting data, actually, as we move forward, and shows us where we can focus our care. I just want to go through, we've got a couple of questions in the Q&A, and can I remind you, if you want to ask a question, please put it in the Q&A box. Maya asked us a question, which I think we'll talk about right at the end, about carbetocin. But Wilfred Inzama asked an important question, I think, to you, Lale. You talked about maternal mortality rate in fragile states. And that's clearly a problem, but actually there's an awful lot of countries which aren't necessarily fragile, but which are taking in a lot of refugees, where there's internal displaced peoples camps. How do you try and reflect that in the global statistics? Because that's it's confounding, isn't it, of the data? Actually,
it's a very good question. But I mean, the countries that are included in the World Bank classification as fragile versus, because there are 2 groups that I mentioned. One of them is the conflict-affected settings, and the others are socially fragile countries. Some of them actually are the refugee receiving countries. So, so the MMRs that we calculate for them are not about the refugee populations versus the populations living in those countries, but in general, the overall national MMR calculated for these countries. So because of the limited data, we are not able to go too much in detail. But if, I mean, we are happy to share the list of those countries that are in that category, in those two categories, and the MMRs are at a national level is higher than some of the other countries that are not as defined as conflict affected and fragile, socially fragile countries.
Yeah, okay. Thank you, Lale. Anybody else want to comment on that from the group? Well, if not, maybe I can ask a question, because I wanted to ask about the COVID issue, because I mean, it's very clear. I mean, it's remarkable, isn't it, the sudden increase that you see during the period of COVID. But I guess it comes on to you as well, Jenny, as to that will have affected certain types of death. And in the UK, we say, well, there's COVID maternal deaths and then there's non-COVID maternal deaths. And actually, we quote the figures, both the overall figures and then those which are not specifically deaths from COVID. But Lale, in your work, I don't think you showed, you said the proportion remained the same, but if you took out those women who'd purely died of COVID, there'd still be a peak, wouldn't there?
Yes, and I think I'll give this floor to Jenny because she knows better in those details. So I think she's in the context of causes, I think she will have more insights. Yeah.
Yeah, so the spike that Lale was showing is those women where the cause of death was the interaction between the pregnancy and COVID-19 disease. So it was those women where they were COVID maternal deaths, not all COVID deaths, because sometimes, as you rightly say, a woman may die of COVID, but the fact that she was pregnant, her state of pregnancy was not deemed by the person, the care provider, and the person who classified her cause of death as being the underlying cause of death. It was incidental so it's Lale was already focusing in that spike on those specific deaths which were maternal deaths only. And this was something which was very challenging for us to estimate, because the data, as you can imagine, it is quite limited, but it's also changing quite quickly, and different countries took slightly different approaches in how they categorize the data. So we had to make various assumptions and look at the relative risk between death amongst pregnant women who also had COVID-19 and women of the same age who were not pregnant. And it is possible that in future iterations, when more data becomes available, because countries often have a 1, 2, 3, 4 year lag in reporting, it is possible that we will be able to do a more granulated job in the future at that spike. But the key answer is that the peak that Lale presented is not all COVID death. It's the specifically maternal COVID deaths.
Yeah, okay, and shows how health system, it reinforces your point. I think that health systems are critical, and if you disrupt the health systems, actually you get huge spikes. Sherry, do you want to comment?
Yeah, thanks so much. I want to add on to that question, and it's probably a question that doesn't have a great answer yet. I imagine doctoral dissertations may be written on this or are being written, but we know that some of those deaths were simply access related. There were curfews, women couldn't get into, hospital or whatever. Do we have any sort of more details about access being the issue, or women not coming in for care during the COVID pandemic?
You want me to take that, Lale?
Yeah.
Yeah. So we don't directly use that in the analyses that were presented today. But you are, of course, right. There was concern that anything which causes disruption to timely quality care is logically going to lead to an increase in mortality. That could be the COVID-19 pandemic. It could also be, for example, the impact of cuts in ODA, which we're seeing in many countries. There is a strong analogy there. We know that when women don't receive care when they need it, more adverse outcomes take place. There were various surveys which took place during the pandemic. We called them pulse surveys, so kind of rapid, quick surveys to stakeholders asking about the impacts of disruption. What we tended to see during the COVID-19 pandemic is, for most countries, whilst it did differ, because many countries were hit in different ways at different times, countries took different approaches in terms of their public health response. It tended to be relatively short-lived, the acute disruptive period, a matter of months rather than the 3 years of the pandemic. But exactly when that time was differed. And there were certainly reports of quality of care being impacted. So we do assume that some of the increase in mortality was for such reasons. Thank you.
Yeah, no, there's a good PhD in there somewhere, isn't there? Because it's interesting also looking at your figures on different countries. The famous Hans Rosling graphs of GDP against maternal mortality, where you see that very direct relationship. Presumably for hemorrhage, you'd see a very strong relationship, whereas others actually are less preventable, aren't they? Like embolism, so you see them overrepresented in the higher income settings because they're just far more difficult to prevent, whereas maybe the PPH ones we're in a more fortunate space. Let's just have one more last question before we move on to Ken. So Lale Say, excuse me for my pronunciation, is asking about sepsis and the distinction between puerperal sepsis and then also post-abortion sepsis, and how people try to eke those out, because there's sort of postnatal term sepsis and then there's early abortion sepsis. And how did you work about classifying those? Sorry, this to you, Jenny.
So we follow the ICD. So it's pregnancy-related sepsis is the term we use, not just sepsis. And then there's a separate category, which is pregnancy with abortive outcome. And
so post-abortion sepsis would come under that post-abortive outcome rather than the pregnancy sepsis.
Mm-hmm.
Perfect. Okay, fantastic. Thank you so much. Okay, let's move on to our last presentation then, which is Ken Mugabe, who's going to speak to us now. So Ken is an obstetrician, gynecologist in Mbale Regional Referral Hospital in Uganda. He's an associate consultant there. He's team lead for the Elgon Local Maternity and Newborn System, which you'll hear about in a second. He's also a PhD student at the University of Liverpool with interest in maternal sepsis, postpartum hemorrhage, and hypertensive diseases of pregnancy. He's a member of the AOGU, the Association of Obstetricians and Gynecologists of Uganda, and a fellow of the East Central and South African College of Obstetricians and Gynecology, EXAOGS. He's program director of the EXAOG Mbale site. So thank you very much for speaking to us this afternoon, Ken. It's fascinating when you look at the particular country lists, and I'd encourage everyone to look at the different country lists which were published earlier in the year. Maybe somebody can put a link in the chat to them. But if you look at the individual countries, you'll see there's certain countries which have really bucked the trend. And we talk about a 40% reduction overall, and you look at India, I think, and Pakistan. South Asia have got something like 75%, and there's other places in sub-Saharan Africa. So I think in Uganda, there's something like a 60% reduction in 65% reduction in maternal mortality since 2020, and a lot of it is down to individual projects on the ground. Uganda bucks the trend a little bit, because although the trend is to slow down, actually Uganda's has sped up in terms of its reduction, and a lot of it is down to projects like this one, which Ken's going to tell you about. So over to you, Ken. Thank you.
Thank you, Andrew, for the kind introduction. And good afternoon, good morning, good evening. So allow me to share with you one of Ugandan's great interventions and innovation, the government of Uganda introducing the local maternity and neonatal systems. And I'm sharing an example of one pilot project from the Elgon local maternity and neonatal system, which is, Uganda has about 15 LMNSs, and but Elgon is one of these and was a pilot, which was inaugurated in 2022 as a collaboration and accountability platform, for maternal and newborn health. It's situated quite remotely, about 245 kilometers from the capital of Kampala, with a catchment area of 5.5 million, according to the 2024 national census. This setting is quite unique in a sense that the population has a very high fertility rate of an average of about 6 children for every woman, and a teenage pregnancy rate of about 24%. So it is quite unique as far as in our context of postpartum hemorrhage. So the Elgon LMNS was formed with the current roles, a number of them. One of them was to provide regional leadership for maternal and newborn care, spearhead capacity building, coordinate all maternal and newborn health response and care, track and redistribute medical commodities and essential medicines to facilities that are acutely deficient, identify non-functional equipment within their catchment area, our catchment area, and mobilize for them to be repaired, lead awareness campaigns to sensitize communities about all direct causes of maternal mortality, which PPH is part. Participate in advocacy and collaboration activities, both regional, national, and international, to mobilize partners so that they can contribute resources towards improving indicators in our region. But also, the issue of human resource for health was very key for us to advocate for, especially the critical health workforce for maternal and newborn health, and finally research. So that time in 2022, when the Elgon local maternity and newborn system was formed, one of our spring areas was that we noted in our data set us off was the fact that our region was having a high prevalence of postpartum hemorrhage to a tune of about 52.3%, like you see in that table. And this is where our work began from and spark our activities. So then we try to look around to see the kind of problems we had, what could have been the causes in 2022. And we found out that we had very low numbers of critical human resource for maternal and newborn health in the region. We had many non-functional CMOC sites, poor referral systems, frequent stockouts of essential medicines, especially for this context, oxytocin, misoprostol, and the usual commodities that we use in the identification and management of postpartum hemorrhage. Most of the equipment in the health facilities were broken down, especially in theaters, where most of the response is, especially escalation, and laboratories, which we need for diagnosis or monitoring these patients who have postpartum hemorrhage. We also had very low utilization of data unit on the wards to spark response in these facilities. We had, most of our facilities had non-functional MPDSR committees and processes. There was no evidence-based practice. We couldn't find any of these guidelines which were updated in the in these health facilities, especially that we had just passed, or we had just launched the new essential maternal and newborn health care guidelines. They were missing in most of these facilities. We didn't have identification of high-risk pregnancies in our dental clinics. Blood distribution was not timely in most CMOC sites, and most of some of the CMOC sites were not pre-qualified for blood transfusion. And to sum up all this, the leadership and accountability in the region was at its worst. So we sat down as a team and laid down a 7-point plan on how to improve our indicator, especially on hemorrhage. And these were the 7 to improve on governance, leadership, and coordination in our region, strengthen clinical capacity and service delivery, improve emergency response and referral systems. We make sure that our data, surveillance, and accountability is improved upon, community engagement and demand generation, develop or start high-risk antenatal clinics in the region, and also have a few innovations around referral tracking, reward system, and research. And I'll try to elaborate on what we did under each of these points. So under governance and leadership and coordination, there were about 2 or 3 things that we set in place. One of them was to mobilize our local political leaders in the region and put them in one room with the policymakers. That is, like you can see the Minister of Health together with the Director General of Health Services in the room, and then the health workers as well, such that we could plan together to see how we can bring down these high numbers of deaths due to hemorrhage in our region. You remember that the parliamentarians are the people who allocate resources, and then the Minister of Health send them to the health facilities for spending. So these people are very important if we are to bring down maternal deaths due to hemorrhage. So that was one of our key deliverables. This is done every year. We put them in the same room once every year to deliberate on our progress and also the gaps that we still have. Secondly, what we did or what we do on a day-to-day is resource mobilization, especially for financial support from regional implementing partners. And there are several of these. These ones can be range from NGOs to banks, to corporate groups, and even individuals. So we move up and down, try to mobilize resources so that we can reach out and do our activities in the region. And then lastly, under leadership and governance is the issue of support supervision, where we implement regular on a monthly basis support supervision and mentorship to our spoke health facilities in the region as specialists. So after that, after its inauguration, like you can see, we formed a group of that comprise the secretariat, eminent secretariat, which has an obs-gyn, a pediatrician who is a neonatologist. Then we have a midwife there, and then a representative from the implementing partners. And then key to hemorrhage is the head of the regional blood bank. So it's part of this secretariat where we plan and then effect our responses in the region. The other thing is during support supervision, when we move out, these are the different activities that help us to pick up gaps within the region, and then also to respond appropriately. Now, one of the things we do is that we join MPDSR meetings in the different facilities that we go to. We also join ward rounds with the doctors there and provide peer-to-peer mentorship. We see how they manage patients and we give feedback on site. That we do also confidential inquiries where we, whenever there's a maternal death, of course, this is sanctioned by the National MPDSR Committee. And then we, as a leadership within the region, we go to these areas that have had this maternal death. We interact with the district health team, but also with the community, and delve deeply into what caused the maternal death and what could be the solutions. Remember that this LMNS, or the local maternal and newborn systems, is hinged on finding local solutions for local problems. So that's what we do. And then the other thing, what we do is that we interact with the health facility leadership, like you can see in this photo, to first of all give them feedback on our findings, but also to set recommendations for the next time. We look at human resource. Looking at uterostars is one of the things that we do. And then also we look at how they store blood within the facility. Storage of oxytocin drugs, especially oxytocin, is very pertinent when we go for these visits. But also we join them in theater to manage patients together so that we can assess their skills on how to do safe cesarean sections. Yeah. And then finally, during our support supervision, we endeavor to find out that these people have emergency postpartum hemorrhage kits well set, like you see it there in the labor ward. And then we look at the contents. We constitute them together as a team. And then at the backdrop, we are able to look at our data and find out this hospital we go to, basing on what Ministry of Health sent. You know, do they have the non-pneumatic anti-shock garment? How many were they given? Do they have the drapes that estimate blood loss? We are able to find out, and we're able to match them with our findings. The second plan the second goal that we do is to strengthen clinical capacity and service delivery. Under this, as a local maternity system, we've played a very big role in kickstarting specialized training within the region for obstetricians and gynecologists and anesthetists. This started in 2023, and because of this, we are seeing increased deployment and equitable distribution of key and critical human resource across the high burden districts in our region. But also we emphasize and have included the emotive training as part of the curriculum, the training curriculum in the university that and the training institutions that we have in our region. We also do in-service capacity building, where we've, like you see up here in the right-hand corner, we've, with the help of the Ministry of Health, we've had a training and formed a team of regional emotive trainers. You can see them. We are 4, and these ones are able to conduct the emotive training for the entire region, and so that we can have minimal trainers at district level. We also have monthly virtual and on-site low-dose high-frequency simulation-based trainings on emotive in our region. Lastly, under this, we also track and ensure continuous availability, safe administration, and storage of uterotonics, like you've seen. But we don't only stop at that. We also, if need be, redistribute these commodities when we find facilities that are lacking, and then we get them from facilities that have them in excess. Yeah, of course, that one is just a demonstration of the simulation-based training that I've talked about. And then another thing that we emphasize is peer-to-peer mentorship. As you realize that in our country, especially in our region, most of the deliveries do happen at lower health facilities, Health Center 3, which where deliveries are basically conducted by midwives. So we emphasize, after training one midwife in a district or from a health facility, we emphasize peer-to-peer mentorship. Midwives mentoring fellow midwives on how to identify and manage postpartum hemorrhage. But we also had some few innovations, like the Nurses and Midwives Research Hub, which started, and then journal sessions. All these are chaired and coordinated by midwives and also clinicians in our region. So the midwives mentor midwives, and also the doctors mentor doctors, like you see here on the right side. Through the LMNS, when we track that there's a problem, we bring the doctors and we mentor them at the regional referral hospital and then send them back to their facilities armed with better knowledge and skills. So the third thing we look at majorly is improved emergency response and referral systems, where basically we look at facilities. We look at suboptimally functioning facilities, and we advocate for their full functionality. We look at what they are missing and mobilize those things from partners, from Ministry of Health and others. In 2022, we had about 6 non-functional facilities, and we've seen them functioning over these 3 years. So we have now 22 of all our CMOC facilities fully functional. We also try to emphasize referral and improvement in referral and transport systems. We have our WhatsApp group, Elgon LMNS WhatsApp group, and every stakeholder is on this platform. For instance, when you look here, the transportation of the coordination of the ambulance system and also delivery of essential commodities throughout the region are coordinated on this WhatsApp group. For instance, when you look at here, there was a health worker who needed blood as an emergency, and they were able to put out the stress call on the WhatsApp group, and then people swung in action. You can see here that someone is running to take this much needed blood unit to the health worker who needs it. In our region, we emphasize transporting the blood to the facility that needs it instead of referring the patient, because referring a patient means you're referring the entire family, sometimes the whole community, and it destabilizes the entire structure within the support structure back home. So when someone needs a commodity like blood as an emergency, they push the stress call on our WhatsApp group where all stakeholders are, and they're able to elicit a response. We're able to swing into action and take this much needed commodity to the health worker who needs it. The other issue that we've emphasized over the years is data surveillance and accountability. Here, we've established MPDSR committees in all districts, and they are now functional, and we conduct regular review meetings. Every month we schedule meetings in different facilities where we go and take part in these review meetings, maternal death review meetings. We also document and address any systemic failures contributing to PPH deaths through weekly LMNS regional meetings that we hold every week. We share data. You can see our dashboard that we share here every week, Elgon LMNS, and we are able to see week per week what maternal deaths are attributed to postpartum hemorrhage, what were the gaps, and we generate responses locally using our local means. And then where we are defeated, we can call upon the ministry to come in, but most of the responses are locally generated. We also, we also conduct confidential inquiries, like I said, and audits. And so far we've done 6 confidential inquiries into maternal deaths. And these ones have informed the Ministry of Health on how to change practice and policy. Another very big strength that we have in Elgon LMNS is community engagement and demand generation. Here as Elgon LMNS, we run weekly radio talk shows, and we talk about different topics, PPH being one of them. And also we conduct annual awareness community drives. And in August, the whole month of August is for PPH. And we are in preparations right now, preparing for the next month of our PPH awareness month, day by day. For all the 31 weeks, we engage the community in educating them and sensitizing them on what PPH is. We also create strategic partnerships with other implementing partners so that they join us in these efforts of awareness. Remember that if you're to communicate with these communities, we need to communicate with them effectively. And one of the things that we've spearheaded in the country as LMNS, as Elgon LMNS, is to translate most of these IEC materials into local languages such that we can communicate better to our communities. So like you can see, there's the English version and then the 2 different local languages in our region. We've also been strong on introducing high-risk pregnancy clinics in all our CMOC sites in the region, the 22 of them. These are antenatal high-risk pregnancy clinics where we identify mothers who are at high risk of developing PPH, and then these ones put in a different record book, and then once a day they are seen by a doctor in a special high-risk clinic, and a delivery plan is made for individuals, and then responses, or they can either be managed in that facility or they can be linked up to a higher level of care. And this one has helped us to plan for them better and intervene early. The last one is on innovation, of course, and technology. One of them that we've done in Elgon LMNS is referral tracking. With using ODIC and ODK app that we put on the midwives' phones in the labor wards. So when a patient is being referred to maybe the regional referral hospital, the midwife from lower health facility is able to type in into her phone on the ODK the particulars of the patient, why they need to refer, and this one will reflect on the phone of the midwives in the hospital where they are referring this patient. But I'm also able, as the coordinator, I'm also able to see this kind of communication on my laptop. Yeah, so it keeps me it keeps me aware of what is going on in the entire region as far as referral of emergency is concerned. The other innovation that we've had, one of the key things that we noted is staff burnout, low mood, and that kind of thing. A reward system we thought is very important, something that is simple to do, like recognizing ourselves. We thought it's very important. So we came up with what's called the Wall of Fame, that is one of our walls in the hospital, in the regional referral hospital, which we started in August 2023. And on a monthly basis, using a tool, we are able to assess as a team of, we usually sit a team of the secretariat, and then we are able to assess the best performing health workers. Then we display them, like you can see here on the Wall of Fame, and everybody as it's passing around, able to notice that this is the best performer.
And we need to wrap up. We've got questions and we're at the end of our time. So
Good.
Do you want to just quickly tell us whether it's worked?
So what have we noticed after these interventions? We've noticed our antenatal attendance increased by 18%, with the 4 antenatal clinics improved by attendance by 12%. Health facility deliveries are also improved from 60% to 75%. In our region, improved staffing from 79% to 83%. Referrals have also reduced by 32% to the regional referral hospital because we've built capacity in the lower health facilities. So most of these things, emergencies are being handled in the lower facilities. And definitely when referrals reduce, also C-section rates reduced by 13% in the regional referral hospital because it has been decongested. We've also seen our postnatal care attendance increase from 50% to 60%, so we can be able to detect the secondary PPH, and then also regional, to sum it up, the PPH cases in the region. Though the identification of the PPH cases has raised by 37%, but the deaths due to PPH have reduced by 34%. Yeah. So in conclusion, yeah. it is very important to support the local maternity and newborn system in Africa, in countries where they have been set up, so that we can improve leadership and sustainable investment through these systems, so that they can find local solutions for local problems. Thank you.
Fantastic. Thank you so much, Ken. Fascinating to hear about the work that's going on and which are the real life stories behind these national trends. We're over time. We said we were going to be an hour and a half, but this is too fascinating to stop. I don't know, from the IT point of view, those running the IT, can we have another quarter of an hour? I appreciate that some people will have to leave because we did say we were going to finish at half past the hour, but maybe I can make an executive decision we continue for another quarter of an hour so we can have a panel discussion. I hope that people from the panel will be able to stay, because we've got lots of questions coming in, and it would be a shame to cut it off. Can we bring the panel back and we can just get some of these questions done? So there was one question which has been there right from the start, actually, Ken, which they're talking about carbetocin. There's been so much talk about carbetocin and how this may solve many of our problems. You've got this massive, in Uganda, 65% reduction in maternal deaths. How much has carbetocin been part of that?
Yes, Andrew, we've just had, whereas there's been training on how to use carbetocin from last year to this year, we've only had the doses of carbetocin coming into the country this year. We have about 4,000 doses right now in the country this year. Definitely it's not enough, but it will go a long way to help reduce on the deaths due to postpartum hemorrhage. So these figures, there's no contribution of stable carbetocin, but in the years to come, we believe we'll be able to deep this further. Thank you.
Yeah, thanks. I mean, I knew the answer actually, but I think the point was that actually all these things that you showed there were system things. We can get all improvements. Maybe carbetocin will help us if you've got cold chain problems. There's other innovations that we can bring in, and they're all good. I'm an innovator myself. I love innovations. But actually, a lot of yours were not innovations. The things you were showing, they were good management, they were good structural, they were checking on people, on the deaths going on. And actually, those are available in every country in the world. There can be an awful lot you can do without our favorite intervention, and we've all got our favorites. Okie doke. So let's just go through some of the questions. We've got the one on carbetocin there. So there's an interesting question from Guatemala, where they're talking about communities with no telephone coverage. And WhatsApp has been quite a major part of the work that you've done, holding that community together and keeping good communication. They say, is there an alternative to the WhatsApp group? How important is that to you as a way of keeping communication?
Yes, Andrew, and thank you for our colleague from Guatemala. In Uganda, we have a good penetration of WhatsApp to the lowest facilities, really. And we saw it as a low-hanging fruit, especially during the COVID outbreak, in terms of communication. That's why we really chose to use WhatsApp for our major interventions and coordination and making up. Besides WhatsApp, others are not sustainable. Yeah.
Yeah. Okay. It'd be interesting to hear from Guatemala what their alternatives are, because I'm sure there are good alternatives. I don't know, Lale, Jenny, did either of you want to come in with any comments about the sort of actions going on in the ground? Because I know yours is very much high level, but actually the high level is made up of all these little levels, isn't it? I wonder if either of you had any comments.
Maybe one thing I just wanted to reiterate what you just said, Andrew, and congratulations to Ken and the team in Uganda. I mean, what you said actually, has to be highlighted. Is actually we usually say we know what needs to be done. But then this is an excellent example of, as you said, how to organize, how to make sure that all different pieces of puzzle can be organized and monitored and supervised so that the machinery works. So I really wanted to first congratulate, but also, maybe a kind of a statement from this webinar is really the best is to really, to find, you said they're not, but maybe innovation is actually how best to organize. To find innovative ways to, how to pull all these different items together, because we know so long that, this is an area where a concerted action and system-wide action is needed, community level, health system level, health worker level, but really needs to be well organized. So I just wanted to, reiterate what you actually said, Andrew.
Okay. Thanks, Lale. Jenny, any comments?
No, not specifically on this question.
Okay, great. Okay, well, let's take another question, because people are interested in the Q&A about commodities, Ken. And that's been a long-standing problem, hasn't it? So there's people saying, how do you tackle issues surrounding availability of commodities? It's such a major problem. Somebody else talked about uterotonics. How do you, but also postpartum family planning. A lot of these require commodities, and it's a continuous problem. Is that something you've been able to tackle? And if so, what's the key that people can take away?
Yeah, like Lale has said, coordinating all these things it's very key. Back here at the National Medical Stores usually shares with me whenever they deliver drugs to my region or health facilities. So they share with me the different quantities they have delivered. And I'm able to know that this facility has this quantity, this facility has this quantity. Now, during our routine support supervision, I'm also able to see, because like you saw, I not only check on the health worker in the ward, but I go to the stores, I go to the pharmacy, everywhere. So I'm able to know the stocks in the different health facilities, and I'm able to know which facility is missing what, and I'm able to redistribute. Where I find a facility that is short of this, especially oxytocin or now histopathocin or something, I know which one has excess. So I use the leaders within the districts, dodge, of course, the bureaucratic ways of transferring these things, and then I'm able to bring the drugs from one facility to another. Yeah.
And do you think it's been important, the tying up between Ministry of Health clearly is absolutely critical in all this.
Yes.
But often you
Yes.
get projects conducted by individual hospitals or communities, and it doesn't necessarily tie in with the Ministry of Health. But somehow you've managed to compress that gap from the front line right up to the Ministry of Health in Kampala. How have you achieved that? Because it's actually, they need to know actually where the problems are on the ground. How have you bridged that gap?
Yes, we have technical working, local maternity technical working group, which has all the local maternity coordinators of the 15 local maternity systems. And on this technical working group, the leaders of the Ministry of Health there, and we meet regularly, and we're able to update them on what is on ground, what we've been able to do, and what we're not able to do locally. Yeah.
Fantastic. Thank you. It's really a lesson to us all. Sam Anonge, did you want to come in?
Yes, thank you so much, Andrew. I just want to thank Kenneth for that great presentation. And what you talked about commodities is actually a big thing. And you mentioned the redistribution. Still, the WhatsApp group have actually helped, where one facility is out of shortage of oxytocin. Remember, midwife just types, I don't have an oxytocin here, can somebody rescue? And other colleagues from other facilities are able to swing in and say, I have some, so that you are able to redistribute. And it is within the policy of Ministry of Health that within the local maternity system, you can redistribute whatever commodities you have in order to save one facility when there are actually challenges. But the other thing was what the ministry has been emphasizing is training on forecasting, because if you're able to know how many patients you're likely to get, then you're able to request for it from national medical stores, that you don't end up with actually shortages. And that is an area which we have been emphasizing, that can we use the data from the previous year to help us plan for the following year. It is coming, it's a challenge, and but it's something which is getting into the system and health workers, that if you plan better, then the commodities can be availed on what patients you are likely to manage. That's the little I just wanted.
Yeah. No, that's fantastic. Thank you very much. I think that's all very useful, isn't it? How you try and coordinate care, how you try and pull it all together. Let me just have a look at the question and answers. There's lots of thanks coming in. So maybe the final question is from Josephine Nabukira, who's asking about the high-risk clinics. Because that's something which is part of the strategy that you've brought in. But she says, well, how actually does a high-risk clinic reduce the risk of death to high-risk mothers? What are you able to do within that clinic which you weren't able to do before?
All right. Yeah, so remember, a high-risk clinic is designed around a doctor and not a midwife. A doctor must be part of the team that manages these or that takes decision for these high-risk clinics. Now, initially, the midwife is able to identify a high risk in a pregnant mother. For instance, let me say a mother has 4 previous scars, or she's anemic. Then she will record this patient in the high-risk register, flag the risk, and then give an appointment for the high-risk clinic when the doctor will be there. So when that day comes for the high-risk clinic, the doctor is in, and the midwife, and this midwife will share with the doctor her findings, and then they plan together. They make a birth plan for this lady together with the doctor and the patient as well. They make a plan for delivery. In so doing, it is able for the patient to appreciate their risk, but also to appreciate the plan that the health workers have put in place together with her. But also in this high-risk clinic, this health worker, if they realize that the risk, they cannot handle it at that level of care, they're able to link this mother to the next level of care in this very high-risk clinic. Yeah, so
part of all
develop
the
a plan
communication
and link up. Yes.
Brilliant. Okay, well, I'm so sorry. We need to leave it there. We've already gone quarter of an hour over, because we maybe should have a whole webinar by the community of practice on these local maternity systems, because they're things which everybody, I think, can implement. Well, it's not easy, of course, but they are not. They need organizational skills rather than any particular intervention there. So I think we should finish off at this point. I want to thank Lale and Jenny and Ken for what's been a fascinating afternoon. Thank you for your insights. I hope that we've given some degree of hope for the future. Things are going in the right direction. There's lots of interventions. Things can change. Things will get better, and it's a thanks to everybody on the call and to people all around the globe for everything they're doing for reducing maternal deaths, especially from postpartum hemorrhage. Sam Anonge, is he still there as chair of the PPH Community of Practice? I don't know if you just wanted to finish off, or hand over to you to close the session. Thank you very much.
Thank you so much, Andrew, for taking us through this, and I want to appreciate the panelists and the presenters, Lale Say, Cresswell, and Kenneth, for enlightening us and bringing us new information. The community of practice brings regularly these updates, and we're encouraging members to join that community of practice, that you become a member, that there are several updates which can help us move together as a global community. I want to appreciate you for joining, and there's a link for you to become a member, which is shown here. Please click on it, and it doesn't restrict us to only midwives obstetricians, but when we are together and when we update ourselves, then we can be able to reduce mortality to basically PPH. Otherwise, you'll be receiving other updates as regards the next line of topics. Possibly there's another one in October, and this will be shared in different forums, and encourage you basically to join. Otherwise, thank you, Joma, so much. I'd like to bring this meeting to a close.